Good evening, everyone. So welcome to our webinar number 93 on evaluating and managing thyroid function by Alaka ma'am. So we welcome Alaka ma'am and request her to start her talk. Ma'am, you can start.
Good afternoon, everybody. Okay, so I am going to talk about that the doctors in family practice also can set up a thyroid clinic. And therefore, let us see how we can identify thyroid problems and what needs to be done. Now, thyroid, a patient himself presents with thyromegaly. Patient will come to us. So in what way the patient can come and how we can think about his thyroid problem. So patient presents with thyromegaly. Nowadays, it has become like an epidemic. Everybody little fullness in the neck, and they will come and ask me. I ask them, what is the problem? Thyroid. What is the problem? Thyroid. I said, but what is the problem? I said, thyroid everybody has, even I have a thyroid. So what is your problem? Unfortunately, our patients, they don't have any symptoms or signs, or they are not trained to talk about their symptoms. So they just come, they have any fullness in the neck from anywhere, and then they say that it is thyroid. So patient presents with thyromegaly. I'll show you how to examine that. Then patient presents with symptoms of thyroid dysfunction. The symptoms suggestive of thyroid dysfunction. That means the function of the thyroid has become less, that is hypothyroidism, or thyroid is hyperfunctioning, that is thyrotoxicosis. So both of them will have different symptomatology. So patient can present with symptoms. From the symptoms, we make our diagnosis and investigate the patient accordingly. Then there are certain special situations in which we need to examine and evaluate the thyroid. Now, this is when we evaluate the thyroid, we need two things. We want to do a morphological evaluation and functional evaluation. What is the morphological evaluation? That the thyroid gland is enlarged. So it is a diffuse goiter. It is diffusely enlarged, so we call it as a diffuse goiter. It may be multinodular goiter. It may be a single nodule. It may be just an adenoma. And therefore, this morphological evaluation will be done by imaging. Then the functional evaluation. Functional evaluation is by measuring the hormones secreted by the thyroid. So a patient, the hormones are normal. So we will call the patient as euthyroid. The hormone level is increased. So we call it as hyperthyroid. The hormone level is decreased. We call it as hypothyroid. So that will be a hormone profile. So in addition to this, when we combine this morphological and functional evaluation, we get permutations and combination. So it may be a diffuse goiter, which is euthyroid. So euthyroid diffuse goiter. Diffuse goiter with hyperthyroid because the levels are high. So we will say diffuse hyperthyroid goiter. Multinodular hyperthyroid, multinodular hypothyroid. So this is how the permutations and combinations will do. That means we have done both morphological and functional evaluation. So when we want to set up a thyroid clinic, we must understand the physiology of the thyroid. We must understand how to evaluate the thyroid functional and morphologically, and what therapy we can offer. And this is what we are going to discuss. The patient comes with swelling in the neck. Patient comes with some related or unrelated symptoms, or it is a doctor who, after examining a patient, suspects thyroid dysfunction, and therefore we will evaluate the patient. You all are familiar with this diagram. This is the thyroid gland, which secretes mainly T4 and small amount of T3. This T4 is peripherally converted into T3 because T3 is an active hormone. And based on this peripheral conversion and peripheral actions of the thyroid and the hormone, if the levels are adequate, then there is a negative feedback given to the pituitary, and then it also is given to the hypothalamus. In other words, if we see the thyroid physiology, it is the hypothalamus which secretes thyrotrophin releasing hormone, TRH. This TRH stimulates the pituitary to secrete thyroid stimulating hormone, and this thyroid stimulating hormone will stimulate the thyroid to secrete T4, some amount of T3, and then this T4 will circulate and it is peripherally converted into T3. So once it is secreted in adequate amount, there will be a negative feedback to pituitary as well as hypothalamus. So this is how the thyroid functions. Now, as you can see, when you are examining a patient with thyromegaly, the patient comes and he says that there is a fullness in the neck. The fullness, as I told you, it starts some of the patients. There is a fullness, there is a double chin. You know, it is all a part of obesity. So from here to here, any fullness that they say, they feel that it is thyroid. And therefore, we have to be sure what we are examining. So you ask the patient, you first see the patient from the front. And when you see from the front, you can see that there is a thyroid swelling in the thyroid area. Sorry. And then you go to this thyroid swelling, you slightly hyperextend the neck, so neck extension. After neck extension, it becomes obvious that there is a right lobe which is enlarged, there is a left lobe which is enlarged, and there is isthmus which is enlarged. As you can see in this patient also, you can see the fullness of the neck, and the patient comes, and when you extend the neck, you will see this thyroid right lobe, left lobe, isthmus. To further confirm this, we ask the patient to swallow. So when he does this act of deglutition, this swelling will move with deglutition. If it is obesity or if it is only fat here, it will not move with deglutition. So you distinctly see a thyromegaly in the region of the thyroid, which moves with deglutition. Then you can palpate the thyroid. When you are palpating, you should stand behind the patient and then palpate the neck. Okay, you see the consistency of the thyroid, you see the extent of the thyroid, and you can see if there is any lymphadenopathy, and then you can even auscultate the thyroid. If you are thinking of hyperthyroidism with increased blood supply to the thyroid, you will get a vascular bruit. So neck extension, movement with deglutition, palpation, and auscultation. Is there no role for percussion? There is a role for percussion. If you can't reach the lower limit of the thyroid, then you suspect that maybe the thyroid is extending retrosternally. And in that case, you will percuss on the manubrium sterna. If you get a dull node there, you can suspect that there is a retrosternal extension. But for that, you ask the patient to swallow. And when the patient swallows, this lower part of the thyroid, if you can reach the lower margin, then you don't suspect a retrosternal extension. But if you can't reach the lower margin, that means that thyroid is extending. So you will percuss here on the manubrium. If there is a dull node, suspect that there is a retrosternal extension. Now you see this goiter so huge, but it is a diffuse goiter. See the smiling face of the lady. In spite of this, so much of a weight in the neck, she is not bothered because functionally she is euthyroid. Secondly, this thyroid is not causing any compression. Otherwise, she will not be smiling like this. And this is the thyroid scan of that patient. You can see diffuse uptake in both the lower lobes, which is quite uniform. So this was a diffuse goiter. Functional evaluation showed that this was normally functioning. Then this is another lady. You can see a single enlargement of only a single lobe. You can see this girl with a single nodule. So these are the types of patients which will come to you. So morphological evaluation and functional evaluation. Now this lady has this thyroid, which is only on the left side. So left lobe is enlarged. The right lobe is not seen here. The right lobe is not also palpable. When I did the scan, the uptake was seen here in the left lobe itself. The uptake compared to my normal patient, this uptake was high. What are the, and this right lobe is not at all seen. There is no uptake on the right side. What are the possibilities? That there is probably agenesis of the right lobe with compensatory hyperplasia of the left lobe. That is one possibility. What is the other possibility? That this particular left lobe is hyper secreting T3 and T4. And when it is hyper secreting T3 and T4, that T3 and T4 with a negative feedback will suppress the TSH. And because it has suppressed the TSH, the right lobe, which is dependent on the TSH, is not picking up any radioactive iodine or technetium. Therefore, here the right lobe is suppressed by the hyperacting left lobe. Okay, so what we call this, that this is adenoma on the left side. T3 and T4 are high. Therefore, I'll say this is toxic adenoma, and that toxic adenoma has suppressed the right lobe. This was that single nodule girl, and this is a sonography which shows that it is a cold nodule. I mean, this is a nuclear scan which shows a cold nodule here. See, this is the cold nodule, and the same nodule on ultrasonography, you can see clearly that it is a cyst. It is not a solid nodule. Then you can do the FNAC, and FNAC has shown us different pictures. And this was FNAC which I had done. And this patient, as you can see here, a papillary formation of the cells. So this was a case of papillary CA. Now I will not go to the malignancy. And for that matter, you can do the sonography. If there is a suspicion, then you can send the patient to endocrinologist or you take a second opinion. So what are the thyroid function tests? The thyroid function test, the functional evaluation, morphological evaluation by sonography, by radionuclide scan, sometimes FNAC, and for retrosternal goiter, we will do a CT scan. For functional evaluation, we will do the hormonal studies. So you will do first the free T4, free T3. Now what is free T4 and free T3? Now T4 is secreted by the thyroid. When it is secreted and comes in the circulation, it is bound to the serum protein. So it is bound to thyroid binding globulin. It is bound to some amount is bound to thyroid binding prealbumin, and some amount is free. So whatever is the free fraction is the active form of fraction. Okay. And therefore, for us clinically, what is more important is the free fraction, which is active. So we will do FT4, FT3. Then, because if the FT4, FT3 are high or low, at the same time, we will also evaluate the pituitary function by doing TSH. And then we will also do thyroid antibodies. So functional test, one will be TSH, that is from the pituitary, free T4, free T3 from the thyroid, and thyroid antibodies, which will give us some idea about the etiology. Morphological evaluation, USG, radionuclide scan, and a CT scan if needed, and FSC. Now, thyroid disorders, most of them we say they are autoimmune disorders, and therefore we will do TPO antibodies. Okay, they are also called as antimicrosomal antibodies. So TPO antibodies, then thyroglobulin antibodies. Now they are of importance only in carcinoma of the thyroid, and then thyroid stimulating immunoglobulins. This is important in hyperthyroidism, but in day-to-day practice we may not need these. So let us now discuss about the hypothyroidism. The hypothyroidism, as I said, there will be low T4, and this low T4 will reciprocally, because it is low, will give a feedback to the pituitary, and pituitary will secrete more and more TSH to stimulate the thyroid. So the TSH will be high and T4 will be low. So in spite of having high amount of TSH, it is not able to stimulate the thyroid. So low T4, high TSH is hypothyroidism. When the TSH is more than 10, we call it as overt hypothyroidism. When the TSH is between 5.5, is up to 5.5 to 10, we call it, normally it is 0.5 to 5.5. So if it 5.4, so if it is 5.5 to 10, we call it as subclinical hypothyroidism. Okay. So when it is Overt hypothyroidism, TSH more than 10. If it is subclinical, TSH is slightly elevated, but it is less than 10, we call it as subclinical. Now, as I told you, there can be a pituitary failure. What we are talking hypothyroidism is a thyroid failure, but there can be pituitary failure. And therefore, because of the pituitary failure, the thyroid is not getting stimulated. So the thyroid hormone deficiency is there. Low T4. What will happen to the TSH? The pituitary has failed. Therefore, TSH also will be low. This is a rare condition, but I'll explain to you. So this is called as a secondary hypothyroidism. So low T4, high TSH, primary hypothyroidism. Low T4, low TSH, secondary hypothyroidism. Now, when we were students, or till about 15, 20 years ago, we used to talk about the signs and symptoms of hypothyroidism. Hypothyroidism, because there is a loss of hormone, everything is dull, everything is slow, except menstruations in the female. Okay. So what the patient's presentation used to be, patient is lethargic. He's, बहुत आलसी पन लगता है, कुछ काम करने को दिल नहीं होता है, not interested. So lethargy, apathy, slowness of the activity, the appetite is decreased, there is a weight gain, there is a constipation, there are facial changes, the skin is dry and coarse, and the voice is thick, except menorrhagia, which is hyper. So everything is slow except menses. So a patient, even menopausal woman coming with menorrhagia, just do a TSH to rule out hypothyroidism. On examination, there is a dull look. The cerebration is slow. If you ask any question, the answer will come slowly. She takes a longer time. The voice is thick and hoarse. There is a loss of lateral 1/3 of the eyebrows. The pulse rate is slow, so there is a bradycardia. There is a pallor. There is a non-pitting edema, which is called as myxedema. And the ankle jerk shows slow relaxation. Now, in good old books, we were taught that there will not be a goiter in hypothyroid cases, because in those days we didn't have this hormone estimation available to us, and therefore by the time patient used to come, the patient used to have a full blown picture of hypothyroidism. I have diagnosed many cases as a spot diagnosis of hypothyroidism. Now, in these cases, the thyroid was completely destroyed by the antibodies, and therefore there was no goiter. But now we are getting a changing profile of the hypothyroidism, because the hormone estimations are available immediately, and therefore only by going by those hormones we can say that the patient is hypothyroid. Now, as you can see, the first lady, the sallow expression. Okay, the lips are thick, the tongue also will be thick, there is no interest in the surrounding, and as you can see here, there is no goiter in the neck. Now, in those days, this I am talking about, I think 1980-85 ki baat hai. One girl came, she had a goiter, so she was operated. Do you see this operation scar? Because most of the surgeons have itching hands. So this girl was operated because of the goiter. Now she is about 13 years old. She had this lethargy, apathy, everything. There was a goiter, but when I did the iodine uptake, and those days I had started doing the radioimmunoassay, the T3, T4 was low. So this was a goitrous hypothyroidism. And in the goitrous hypothyroidism, in those days, we used to think about hormonal dysgenesis. That means the iodine is picked up, but it is not converted into T3 and T4 because of enzyme deficiency. So we used to call it as deficiency in organogenesis. Now the scenario has, of course, changed. Earlier etiology we used to call idiopathic or atrophic, because the thyroid was not seen. Today we know that atrophy of the thyroid has taken place because of autoimmune thyroid disorder. So most of the cases that we have are autoimmune thyroid disorder. Defect in biosynthesis, that girl that I showed you was a defect in biosynthesis. rarely congenital absence of the thyroid, and therefore you get cretinism, and very rarely resistance to thyroid hormone. So most commonly it is autoimmune thyroid disorders. What are the other causes? That there is ablation. That means surgically the thyroid has been removed. So surgical ablation, radio level iodine is given, and therefore thyroid is destroyed. So it is radio ablation, surgical ablation. Then Hashimoto's thyroiditis. You get a small subset in which we get postpartum thyroiditis, and therefore hypothyroidism, and drug induced. That is very important. Nowadays, very commonly we use amiodarone and ethionamide. Both these drugs cause hypothyroidism. Again, I come back to the functional evaluation, and serum TSH normal is 0.5 to 5.5 micro international units per ml. That is normal. But if it is from 5.6 to 10 micro units, we call it as subclinical hypothyroidism, provided T3, T4 is normal. And if it is more than 10, then we call it as overt hypothyroidism. So if you just want to do a screening of the patient, just do a TSH test. And if the TSH is elevated, you can ask them to get a free T3, free T4 done. But if you don't want the patient to undergo a second prick, because patient may feel the doctor is a hesitant or doctor doesn't know this thing, so please you can do free T3, free T4 and TSH in one single go. Now I had conducted a study in the when I was in JJ hospital, and patients came to me only with goiter. There were no other complaints. So I took 150 patients with goiter, and I selected 100 with control. Of these 150, thyroid disorders are more common in females. So I had 140 females and 10 males. 45 patients were euthyroid. All of them were subjected to T3, T4, TSH because they had come with a goiter. Similarly, control group also had subjected for T3, T4, TSH because they come for various reasons. So here 45 were euthyroid while 105 were hypothyroid. So out of 150, 105 patients with goiter were hypothyroid. That means they had come very early, and that hypothyroidism was detected by hormone profile. In the control group, 96 were euthyroid, and only 4 patients had subclinical hypothyroidism. Okay. So when the patient comes with goiter, please do morphological as well as functional evaluation. Now, all these 105 hypothyroid cases, they had no symptoms. I asked them, कुछ तकलीफ है? तकलीफ नहीं है, खाली ये गले में गला सूज गया. And they're all worried because they see a gland every day. 10 times we see in the mirror, and we see the gland, and they have that fear of malignancy. So gath hai, gath hai, gath hai. So it was 105 people who had no symptoms. They didn't complain of it, but when I asked direct questions, this is what I found. 93 complained of goiter, 27 complained of weight gain. This is on direct question. Have you put on weight? Yes. Is there lethargy? Yes. 3 had constipation. Only 2 had menorrhagia, while 14 patients had irregular scanty menses or secondary amenorrhea. So what I am again hinting at, if a patient comes with menstrual irregularity, whether it is hyper, hypo, secondary infertility, please get their thyroid profile done. Bad obstetric history, 4 patients, and galactorrhea. I specifically used to ask, is there any discharge from the nipple? And 5 patients gave history of galactorrhea. Okay, so the profile of hypothyroidism is changing. So you should suspect or get the investigations done. Now, TPO antibodies are done in all these 105 patients when they were detected to be hypothyroid. And as you can see, most of these patients had high levels of TPO antibodies. Now, these TPO antibodies are autoimmune antibodies, and they will go on slowly destroying the thyroid. So it is an autoimmune thyroid disorder. While iodine deficiency can cause hypothyroidism, but now, and that is only in the sub-Himalayan area. But now, as we are fortifying our salt and the food with iodine, this has become less and less and less So today, iodine deficiency is very rarely I can see from Nepal or that sub-Himalayan area. Otherwise, it is autoimmune thyroid disorder. What is the therapy? Therapy is replacement therapy because thyroid is not functioning and we have no medicine to stimulate that thyroid because thyroid has failed, primary failure of the thyroid. And therefore, whatever hormones thyroid is secreting, we have to give. And the best is to give thyroxine, not T3 because T3 behaves little erratically. So we give T4. The T4 is labeled as L-thyroxine or L-thyroxine. And what is the dose? 1.6 microgram per kg of ideal body weight. So if the patient has come with full-blown hypothyroidism, swollen, generalized anasarca, that is not ideal body weight. So calculate the ideal body weight and give 1.6 microgram per kg. Start with a smaller dose. Why with a smaller dose? Because of the hypothyroidism, the heart has become sluggish. There is a bradycardia. And suddenly, if you start that heart to work very fast, then it may cause a heart failure. Okay, it may have adverse effect. It may cause ischemia of the heart because the coronaries also will have to supply that heart if it suddenly starts functioning hyper. And therefore, we start with a smaller dose. Monitor serum TSH. You gradually increase the dose and come to the ideal dose. you know uh, I'll come to that. I start with a small dose and then after 10 days I increase the dose and then I titrate it after 6 weeks. Once you have controlled this hypothyroidism, then monitor serum TSH 3 to 6 monthly because from outside we cannot make out hypothyroidism. Patient may have very subtle symptomatology. The patient may not complain. And in order to see that we have adequately controlled the hypothyroidism, monitor it every 6 months. It's like blood sugar. It is not enough that you have done blood sugar fasting PP and started the patient on treatment. We have to see that the blood sugar is under control. So as a follow-up, I call the patient every month. Similarly here, for thyroid, call them every 3 to 6 months and monitor the TSH. In your first visit itself, you will tell the patient that the thyroid is not working and therefore the patient will have to take this therapy lifelong. The moment you say lifelong, they will make faces. And then you tell them diabetes we cannot cure, hypertension we cannot cure, but we can control them. We can prevent the complication. The therapy is lifelong. So similarly here, what are they losing? They have to take only one single tablet early morning. That's all. You don't have to do any other modes of treatment. And therefore, please convince them that they have to take lifelong therapy and they will comply with it because it is one single tablet that they have to take in the morning. Another important thing that I would like to tell my doctor friends that it is levothyroxine. Okay. Levothyroxine is now marketed by many companies. It is Eltroxine, it is Thyronorm, it is Thyrox, and there are so many names I don't know. But everybody's bioavailability is slightly different. Everybody's preparation is slightly different. Manufacturing is different. And therefore, use the same preparation. If you have started the patient on Thyronorm, and this is also again, you have to instruct the patient that he should not change the brand. He should continue the same brand. You may start with the total dose because the new American thyroid guidelines says that whatever dose that you have calculated on the body weight basis, you can start the total dose in the beginning only. But I am little cautious because there is little erratic response from our patient and unnecessarily the doctor will get blamed. So what I do, I start with 50 microgram. 50 microgram, the one bottle contains 100 tablets. So I tell them 50 microgram, one tablet early morning on empty stomach. So even without brushing your teeth, you can swallow one tablet or immediately after brushing, take one tablet. Then another 15-20 minutes will go by the time they prepare tea and all. So you have taken on empty stomach. After 20-25 minutes, she can have her tea, breakfast, everything. And it is the same time that she will take. Therefore, I say before brushing or immediately after washing your mouth. So take one tablet. That you take for 10 days. Suppose if I have to give 100 microgram dose, so 50 microgram, one tablet daily for 10 days. So how many tablets are now remaining? 90 tablets. So now from 11th day, the patient has to take 2 tablets for next 45 days. Okay. At the end of that, I will do serum TSH level. And based on the serum TSH level, I will titrate the dose. It takes that much time. It takes minimum 6 weeks to see or to show a full response of thyroxine. So after 6 weeks or after these 2 months, the patient can do the serum TSH level. If it is under control, continue the same dose. If it is still little high, then increase the dose. But increment again should be small, by 12.5 micrograms or by 25 micrograms. If it is going to the hyper side, then reduce the dose. From 100, you can make it 75. So use the same preparation, start with a little lower dose and then go on increasing the dose. Monitor regularly serum TSH, and in the hypothyroidism, the cholesterol is high. And therefore, initially when you have diagnosed hypothyroidism, get the serum lipids done. If the cholesterol is very high, then you can start the cholesterol lowering agents. And T4 and T3, once in a while, you will also measure once the hypothyroidism is controlled. You see this boy, he was about 19 years old or 20 years old, and he had come with multinodular goiter, as you can see here. And if I don't know where you can, if you can see this, these are the nodules. But look at his expressions, absolutely sallow expression, pallor. There is a lateral 1/3 of the eyebrows are laced. The voice was very thick and hoarse. He had slow mentation. So classical picture of hypothyroidism. Classical picture with a goiter. So this was goiterous hypothyroidism. Now I didn't have those photographic skills at that time, but if you can see here, there is a thyroidectomy scar. So this fellow, again like that girl, had undergone thyroid surgery. What I am saying, the thyroid is not functioning. But when he had undergone the thyroid surgery, whatever remnant tissue of thyroid was there, it was stimulated by TSH. And because of that, there is a thyromegaly, because the pituitary is really using the chabuk to make this horse work. But even though pituitary is flogging this thyroid has enlarged in size, but the output is still low. So there is no point doing surgery with a goiterous hypothyroidism, because whatever you leave behind is again going to increase. So just treat them with thyroid replacement therapy. So primary hypothyroidism, I told you, most often it is autoimmune thyroid disorder, or it could be ablative, surgical ablation or radioablation. Now, along with hypothyroid, in my study, I said, because nowadays you must be getting Metropolis SRL ka har ek ka report, and they write such a big thing below the report. So I said, let me see, because hypothyroidism is an autoimmune thyroid disorder, and therefore you can also see other disorders which are related to autoimmunity. So I started doing B12 levels in these patients, and 54% cases had B12 deficiency. And that means this 54% patient had autoimmunity, which was affecting the B12 absorption. So 54% had B12 deficiency. Therefore, I further subjected them to parietal cell antibodies, because the parietal cells, now I will not go to B12 absorption and other cases, but that we need a intrinsic factor for B12 absorption. And therefore, parietal cell antibodies will endorse that there is a absence of intrinsic factor. So 53% of these patients had parietal cell antibodies. So autoimmune disorders, they are interrelated, and therefore in many of these patients you will find B12 deficiency along with parietal cell antibodies. What is the significance? Because there are parietal cell antibodies, there is a deficiency of intrinsic factor, and therefore giving oral B12 is not going to help these people. We have to give injectable B12. So pernicious anemia is 10-fold higher in autoimmune thyroid disorder, B12 deficiency again. Rheumatoid arthritis 4.8%. Vitiligo is again common in hypothyroid cases. Now I had read this, and therefore I carried out this study, that there is an increased sensitivity of lactotroph cells to thyrotrophin releasing factor. Therefore, every hypothyroid patient, I used to ask about galactorrhea, if there is a nipple discharge. And along with this thyroid function state, I started doing prolactin levels. Prolactin levels are high in these people. But let me tell you, if the prolactin levels are up to 60 nanogram per ml, this prolactin is not prolactinoma. This is because of hypothyroidism. And therefore, if you get these prolactin levels, treat hypothyroidism and the galactorrhea will disappear. But if hypothyroidism with prolactin levels are more than 60, then treat hypothyroidism. And for this PRL, you will need cabergoline. I had a patient who was taking 4 years or 5 years treatment in psychiatry for depression. And then somebody suggested, so she came to me. I did her thyroid function. Serum TSH was 400, severely hypothyroid. And when I asked her about galactorrhea, she said yes, and it was little profuse. Prolactin levels were something like 270. So I had to treat her with cabergoline. She's absolutely fine now. Now she has one kid also, and she is doing very well. Then thyroid function test. Today in our community, every Tom, Dick and Harry is asking for thyroid function test. So goiter, pre-operative menstrual disorders, any weight gain also people will say, "Arey वजन बढ़ रहा है तो thyroid करो." Edema fit, thyroid करो. Because of the obesity, patients go to gym trainers or dietitians, and everybody asks them for a thyroid function. Now, in thyroid, there is no obesity. In thyroid, you get edema, and because of the edema, there is a weight gain. The cosmetologist also asks for this. And then promotion by laboratory. So treatment of hypothyroidism and is not the treatment of report, but of a patient. Please remember that. So think beyond thyroid. I have to hurry up little. Now this is thyroid and pregnancy. This is a special situation. The pregnancy, we are concerned with pregnant mother. We are also concerned with obstetric outcome, and we are concerned with the fetus. I will not go with the physiology. Alterations continue throughout the pregnancy because the metabolic demands go on increasing. So with the metabolic demands, the thyroid should be adequate. Now, if there is a hypothyroidism, the fertility, first of all, is difficult. And then there are complications like recurrent abortions, miscarriages, abruptio placentae, postpartum hemorrhage, gestational hypertension, and intrauterine growth retardation. In the reverse way, what I'll say, if a patient comes with any of these problems, fertility, infertility, recurrent abortion, please evaluate their thyroid functions. Fetal thyroid develops from anterior pharyngeal floor as an outpost. It moves caudally to the final position by 7th week. It starts functioning by iodide trapping by 12th week. Thyroxine is secreted by 14th week. Significant hormone secretion not seen till 18 to 20 weeks. In other words, that means the fetus is dependent on the mother for thyroxine. By 36 weeks, that means now it is nearing the maturity, fetal TSH, T4, TBG reach adult levels. However, there is a placental deiodinase 3 that converts fetal T4 into a reverse T3. Reverse T3 is a inactive metabolite. So what I'm saying, placental transfer of T3, T4 is considerable, but not of TSH. So mother's TSH doesn't cross the placenta, but T3 and T4, and that is why the fetus is growing. The fetus is getting the metabolic stimulation from the mother's thyroxine. So we have to see that the mother is adequately euthyroid. Hypothyroidism in pregnancy. Therefore, we have to go by trimester specific TSH levels. Normally, as I told you, if the TSH is more than 10, then only we say overt hypothyroidism. But in pregnancy, we have to keep the TSH levels in this range. First trimester 0.1 to 2.5, second trimester 0.2 to 3, third trimester 0.3 to 3 micro international units. So remember, in pregnancy is a special situation, and therefore we have to keep the TSH at these levels. Now, if there is a hypothyroid, non-hypothyroid, preconception counseling is very important. We tell them about the obstetric complications of hypothyroidism, adequate control of hypothyroidism before conception, serum TSH estimation when the UPT is positive. You have controlled the hypothyroidism, but the moment a urine pregnancy test comes positive, do serum TSH at that level, because we have to adjust the dose to keep the trimester specific range. After delivery, the thyroxine dose given, it is continued during pregnancy, and then it should be gradually decreased over 6 weeks. Recheck serum to 3T4 and TSH at 6 weeks postpartum. Titrate the dose based on the TSH levels. Breastfeeding should be continued with this thyroxine. In many countries, the screening of all newborns is done on the 3rd or 5th day after life. That is in the developed country. In our country, this guideline is not yet in place. Subclinical hypothyroidism, I told you, FT3, FT4 is normal. TSH between 2.5 to less than 10. This is subclinical hypothyroidism. But as I told you, even in these cases, there are obstetric complications, and therefore you treat these patients with thyroxine to maintain TSH levels to the trimester specific TSH. Okay. So subclinical hypothyroidism, we treat 2.6 to less than 4.2. We give 1.2 micrograms per kg per day. Then 4.3 to less than 10, 1.42 micrograms. Overt hypothyroidism, more than 10, the dose is 2.33 micrograms per kg per day. Remember, keeping the fetus in the mind, we have to give the thyroxine slightly higher to the pregnant mother. Okay, so subclinical hypothyroidism, I told you the dose, and overt hypothyroidism, I told you the dose. Monitor serum TSH every month during pregnancy till delivery. L-toxin dose in accordance with trimester specific. Postpartum we continue the breastfeeding, and then gradually reduce the dose. What are the other situations where we have to do TSH? Preoperatively, or if the patient comes with bradycardia, if there is a sudden weight gain, in GERD, unexplained constipation, menstrual irregularity, infertility, as a part of preconception counseling. Because as I told you, in most of the cases, the symptoms are very subtle. Patient doesn't complain of any symptom, but do the serum TSH as a preconception counseling in early pregnancy and in cases of vitiligo. In the children, it will be delayed milestones, lethargy, scholastic performance is decreased, there may be depression, then hair loss, dry skin, constipation, change in voice, all these are other indications to do TSH level. Thyroid and surgery. I am not talking about thyroid surgery. I am talking about any surgery. Then we would like to do a serum TSH level preoperatively, because if the patient is hypothyroid, there is abnormal hemostasis, delayed recovery from anesthesia, there may be hypotension, ileus, infections, and CO2 retention. So these are the complications if the serum TSH is high, and therefore nowadays every surgeon before surgery, any surgery, ask for serum TSH levels. Secondary hypothyroidism is a pituitary failure where the T3, T4 are low, and therefore we expect the TSH to be high, but the TSH is also low. and therefore we call it as secondary hypothyroidism. One classical example I'll give you, and that is Sheehan syndrome. The lady delivers, she has a postpartum hemorrhage. Nobody, I mean, people, because she has recovered, the baby is well, so everybody has forgotten. But immediately after the delivery, the first thing that happens that there is a lactation failure. Nobody minds about this lactation failure because there are many ladies who don't get the breast milk. Therefore, everybody ignores it. After that, like, that means there was a lactation failure. Then she doesn't get menses for a long time. People feel that it is lactational amenorrhea. So this is very subtly goes on. And then after maybe 8, 10 years, now she comes with hypothyroidism. Now she comes with recurrent infections, hypoglycemia because of low cortisol level. So in Sheehan syndrome, it is not only TSH is low, but all other pituitary hormones are low, and therefore it requires lifelong replacement therapy. Okay, thyroxine replacement even in children. At the pubertal spurt of growth, we have to adjust the dose because the child will require a slightly higher dose. Now I go to hyperthyroidism. In hyperthyroidism, the active hormone is of course free T3. So free T3 is high, free T4 is high. And because they are high, negative feedback to the pituitary. So TSH is low, less than 0.2. In hypothyroidism, I said thyroid hormones are low, FT3, FT4 are low. Feedback to the pituitary, the TSH is high. So when TSH is high, hypo. When the TSH is suppressed to less than 0.2, it may be hyperthyroidism. The causes are again goiters, diffuse toxic goiter, multinodular goiter, toxic adenoma and all. What are the signs and symptoms of hyperthyroidism? The person is hyperactive. There the person was absolutely lethargic, dull, not responding, cerebration slow. But here everything is hyper. Everything is fast except menses. Okay? Hyperactive. When the thyrotoxic patient is sitting before me, you ask the patient, what are your problems? The patient hardly says any problem. The patient only talks about the goiter because all the hypothyroidisms will have a goiter. So they talk about goiter. They are fidgety. They can't sit quietly. They can't sit still. And then you ask directly, direct question, and then all the answers will come out. So they are hyperactive. You ask them to stretch their arms and see the fingers. The outstretched hand will show you the tremors. There is increased sweating. The appetite is increased. Although appetite is increased, there is a weight loss and there is a frequency of motions. It is not diarrhea. The patient has to go 4, 6, 8 times a day. So frequency of motion. As I said, everything is fast except the menses. So there may be scanty menses, infertility. Therefore, I told you this is overlapping. So if there is any infertility or any menstrual disorder, investigate them for thyroid dysfunction. Leukoderma, then the patient may have tachycardia. Cases of atrial fibrillation, you must subject them to thyroid function. Exophthalmos, then subject them to thyroid function and the goiter. So evaluation of goiter functionally by thyroid functions. See this exophthalmos? The upper limbus is seen, the lower limbus is seen, there is a proptosis, the eyes are staring at you. In the neck, there is a goiter. See this another girl? Again, this is a severe exophthalmos. Lead like all your signs which are described in the books are positive here. So in hyperthyroidism, free T3 is high, free T4 is high, and the TSH is low. What is subclinical hyperthyroidism? Free T3 is normal, free T4 is normal, but the TSH is less than 0.4. That is subclinical hyperthyroidism. What is the management? I told you that the patient is hyperactive. I told you the symptomatology. It is, compared to hypothyroidism, this is very clear cut. The patient says appetite is increased. I am losing weight. I don't know what is the cause. there is a increased frequency of motions, the tremulousness or palpitation, with all that, and the goiter. And if there is a exophthalmos, then it is really staring at you. And therefore, we know that it is hyperthyroidism. Do free T3, free T4, and that will give you the diagnosis. What is the treatment? Treatment is medical treatment with anti-thyroid drugs. There is a radioiodine therapy. By giving radioiodine, the iodine will be picked up by the thyroid. Because it is radioiodine, the gamma rays and beta rays will be emitted by this iodine, and those beta rays will slowly destroy the thyroid. So it is radio ablation. And lastly, surgery, surgical ablation. What are the anti-thyroid drugs? Carbimazole, 5 to 40 milligrams per day. Methimazole, the same, 5 to 40 milligrams per day. Propylthiouracil is a different mechanism of action, 50 to 100 milligram tablet, and that you can give. Along with that, because these hyperthyroid people, they have hypersensitive sympathetic system. And because of this hypersensitive sympathetic system, there is a tremulousness, there is a palpitation, there is increased bowel movement. And for that, to control that, we have to give beta blockers. And the preferred beta blocker is propranolol, 10 milligrams to 40 milligrams per day. The treatment is continued for about 6 to 9 months. And then once the patient is euthyroid, even when the patient is euthyroid, continue it for 6 to 9 months. Otherwise, there can be early relapse. So this is the anti-thyroid drugs which you are going to use. Again, titrate them with your hormone levels. Go on increasing the dose or slightly decreasing. But propranolol has to be continued. Radioiodine therapy. Now, if you go by American Thyroid Association guidelines, the first therapy they say is radioactive iodine therapy. Now, this radioactive iodine therapy will slowly destroy the thyroid. So it will take little longer time for the patients to respond and show the improvement. Therefore, we have to continue neomercazole for quite some time. Okay. But in India, what I have found, one thing is because of the fertility, people are scared to take radioactive iodine. Young female, if we give radioiodine, the American Thyroid Association advocates radioactive iodine therapy even in young female. Only thing is conception should be delayed for 6 months to 1 year. Our people are not prepared. They have that fear and therefore they refuse. So in an elderly female, you can give radioactive iodine therapy because one single dose has to be given. So we do this is iodine therapy. Radioactive iodine is given. We do radioiodine uptake. We do the thyroid scan by which we calculate the weight of the thyroid, and then we have to give a radioactive iodine. Now, if the patient is already on neomercazole, this iodine will not be concentrated by the thyroid. And if it is not concentrated, thyroid will not be destroyed by the beta rays. Therefore, we stop neomercazole 2 to 3 days before giving radioactive iodine therapy. And then the single dose is given orally. 5 to 10 millicuries of iodine is given as a single dose. This does not require isolation, because isolation is required when we give it in malignancy, 100 millicuries, not in these cases. Okay. So if the patient is patient accepts your radioiodine therapy, please do give it. It is given, I think, free of cost in Radiation Medicine Center, which is a part of Bhabha Atomic Research Center, situated in Tata Hospital. So just because you are sending a patient to Tata Hospital, please explain to them that this is not a cancer. This is a department of BARC where you will get it free. Other private hospitals are also giving radioactive iodine therapy. And therefore, either you can put the patient on neomercazole or subject the patient to radioactive iodine therapy. Neomercazole you will continue for 6 to 9 months. Patient becomes euthyroid. Patient is happy. Only in about 10% of the patients there can be a relapse. But with radiotherapy, 10% hypothyroidism will occur every year. So as the years increase, the hypothyroidism will go on increasing. Surgery. Surgery in a thyroid, thyrotoxicosis is indicated only when you have controlled hyperthyroidism by anti-thyroid drugs. Otherwise, if the patient is not, hyperthyroidism is not controlled, and you subject the patient to thyroid surgery, there will be a thyroid storm and you will lose a patient. So control the hyperthyroidism. Then for the goiter, you can subject him to a surgery, because that goiter, there is a psychological fear in that patient. So you can subject. Lugol's iodine is given to decrease the vascularity. And nowadays, total thyroidectomy is done. And therefore, after doing total thyroidectomy, this patient will require thyroxine lifelong. Otherwise, he will be hypothyroid. So this is about the surgery. Pregnancy and hyperthyroidism. Again, it is not mandatory like hypo that you have to do TSH in every pregnant woman, because the fetal growth depends on maternal thyroxine. But that is not the situation with hyperthyroidism. So when we suspect hyperthyroidism, when there is a hyperemesis, when there is a preeclampsia, when there is a heart failure, or there is a history of fetal loss, premature labor in the previous pregnancies, or low birth weight baby. In these cases, you will do the T3, T4 levels in the mother. No radioactive iodine for investigations or treatment. We don't do radioiodine uptake also in the pregnancy. So no radioiodine for investigations or treatment. Propylthiouracil 50 to 300 milligrams per day can be given in the first trimester. Then you can switch over to methimazole 5 to 40 milligrams, and low dose of propranolol can be given 10 milligrams twice a day or something. Breastfeeding can be safely given when the patient is on anti-thyroid drugs. The mother is hyperthyroid, methimazole, now they say, the American guidelines, methimazole is also safe in the first trimester. So you don't have to start with propylthiouracil, you can start with methimazole. Dose to be titrated to maintain upper limit of FT4. So it is not that you treat aggressively and bring down FT4 load. It is not necessary. Keep it at the upper limit, because we want to avoid hypothyroidism both in mother, and if the mother becomes hypothyroid, the child will be affected. So keep the FT4 at the upper level of the normal. Both the anti-thyroid drugs, they cross the placenta. Okay, propylthiouracil and neomercazole. They will suppress the fetal thyroid. So naturally, the fetal TSH will increase. That fetal TSH will cause a fetal goiter. So there is a possibility that when the mother is on anti-thyroid drugs, possibility. Because see, at a hyperthyroid mother, there is usually a scanty menses, amenorrhea, so fertility is difficult unless it is controlled. But suppose if there is a pregnancy that takes place, then you are continuing anti-thyroid drugs in the mother that may cause a fetal goiter. Therefore, in the third trimester, please do fetal thyroid sonography. That is all that I wanted to tell you. It is a caution, so that the obstetrician is clear that when she is going to do the delivery, whether she should attempt a normal delivery or she has to go for LSCS. So this is what I wanted to share with you about thyroid functions, thyroid evaluation, and management of hypo and hyperthyroidism. I welcome your questions, but I'll answer them next time, because now there is no time. I have another meeting. And somebody had by mistake said that I am in Singapore and I'll be giving lecture from Singapore. I am not in Singapore. I am very much here in Mumbai. But Dr. Asrani has gone to Singapore, and therefore I am his replacement for this Thursday and next Thursday. So please send your questions and I'll answer them next time. Okay, thank you very much.
Thank you, ma'am. Thank you so much. I'll share the questions with you tomorrow. And thank you, everyone,
Viti,
for joining. Yes, ma'am. Ma'am, unmute
in
yourself.
pregnancy, subclinical hypothyroidism should be treated. You have to maintain trimester-specific TSH levels.
Okay, thank you, everyone. So see you all next Thursday.